reaction of the body's vascular tissue to the injury, be it mechanical, chemical, bacterial, or the foreign body. Acute inflammation initiates immediately after the injury, and it is the first stage of healing. Inflammation consists of the vascular phases as well as the cellular phases. And these vascular and cellular phases are mediated by various chemical signals derived from the cells and the plasma. The first step of the acute inflammation is vasoconstriction. This vasoconstriction, which is very transient, is followed by the vasodilatation. Due to the vasodilatation, the permeability of the blood vessels increase and the plasma seeps into the adjacent tissue, causing the cardinal signs of inflammation, that is, redness, swelling, heat, pain, and loss of function. Due to the seepage of the fluid outside, the flow of the blood cells becomes sluggish, and thus the blood cells, especially the white blood cells, polymorphonuclear leukocyte, they start rolling over the endothelial wall and they start migrating through it. This process is called as emigration. Following emigration, these PMS, they follow the chemical signals to wander through the tissue. This process of following the chemical signals is called as chemotaxis. By chemotaxis, they reach the bacterial debris and they try to phagocytose it and kill it. This process is phagocytosis. The byproduct of the phagocytosis causes the formation of exudate that contains the bacterial debris, the fibrin, the dead cells, and the dead PMS. The inflammation is mediated by various chemical mediators which is derived from the cells as well as the plasma. We'll be seeing these mediators a little later. Now, as we have a little overview of inflammation, next we'll go in little details of it. As we've already seen, acute inflammation is a response to injury and it has two stages: the vascular changes and the cellular events. The sequence of the events in acute inflammation is the vascular changes and the cellular events that consist of margination, emigration, chemotaxis, and phagocytosis. The cardinal signs of inflammation include the rubor, tumor, calor, and dolor. Rubor is the redness, tumor is the swelling, calor is the heat, and dolor is the pain. And there is a fifth sign, that is functio lesa, or loss of function. The first four signs were given by Celsius and the last sign was added by Virchow. So you have an MCQ here. Next we come to the vascular changes. We have already seen that after a transient vasoconstriction that lasts only for a few seconds, arterial vasodilatation occurs. Because of the vasodilatation, the microvessels become more permeable and protein-rich fluid, it moves out into the extravascular tissue. Because of the movement of the fluid outside the vascular tissue, there is increase in the blood viscosity and slowing of the circulation. So in this diagram, what we see is the formation of transudate and exudate. Exudate is typical of an inflammation. So what happens in the normal tissue? There is hydrostatic pressure, or the pressure that tries to move the fluid outside the vessel, and there is colloidal osmotic pressure. We'll be talking about this colloidal and hydrostatic pressure in the next class. Transudate is when these two pressures are unbalanced and there is leakage of the fluid. When such a fluid leaks, this fluid does not contain much of the proteins because the gap between the cell is not increased. It is only the pressure changes that is causing the transudate. But when we talk about the exudate, as we see in inflammation, what happens is the blood vessels, they become leaky, and because of this there is outflow of the proteins as well as the plasma, and this is the exudate. So here now we can see the difference between the transudate and the exudate. Transitate is a non-inflammatory edema, while exudate is the inflammatory edema. Since there is leakage of the protein content of exudate is high. It is more than 4 gram per dl. The value is important. Transitate has no tendency to coagulate, while exudate shows the tendency to coagulate. The specific gravity is less than this value, that is 1.015, while here it is more than 1.018. Inflammatory cells are found in the exudate, while there are no inflammatory cells in the transitate. And examples we have here the edemas of the nephrotic syndrome. When we talk about the exudate, it is always related to inflammation. This chart is very important source of MCQ, and we have a lot of MCQs on this chart. Next we come to the types of exudate. In that we have the serous exudate, which is seen in tuberculosis and the blisters of burns. Then we have the fibrinous, which is seen in the pneumococcal and rheumatoid pericarditis. We have purulent, which has the pus cells, that is seen in the abscess formation and acute appendicitis. And we have hemorrhagic, which contains the blood cells, which is typical of pneumonia. The first two, you can see the serous and fibrinous, they are common source of MCQs. Next we come to the cellular response. In the cellular response, our first step is the margination. As we saw that the blood, from the blood vessels, the plasma seeps out, and normally, if you see this is blood vessel, this is the normal flow, normal axial flow, which is called as, wherein the cells move in the center and the plasma is in the periphery. Here, what happens due to stasis and the vasodilatation is these cells, they start coming to the periphery. And as they come closer to the periphery and under the influence of the signals, they start adhering to the endothelium. So first is the margination, that is coming to the periphery. Then they start adhering to the endothelium. Once they start adhering to the endothelium, drawn blue here, they start migrating through the gaps in the endothelial cells. So this is transmigration, and once they come out of the blood vessels, they move towards the bacteria. So we have bacteria here and we have the chemical signals, and these extravasated PMNs, they move towards the bacterial cells by a process called as chemotaxis. So in this diagram, we'll see a little bit more in detail how the transmigration takes place. As we have seen that the blood vessels, including the RBCs and the WBCs, they are moving in the center of the stream. Once there is vasodilatation, these vessels, they start coming towards the vessel wall, and usually even in a normal flow, these cells, WBCs, they inspect the vessels periodically. This inspection is called as, but in the cases of inflammation, what happens is we have the inflammatory mediators that bring about the expression of selectin molecules, and these selectin molecules bring about increased rolling. Rolling is nothing but the transient attachment of the PMNs to the blood vessels, and because of the expression of these selectin, the rolling is increased. When we talk about the selectins, we have three types of selectin. We have P-selectin, E-selectin, and we have L-selectin, which are expressed on the leukocytes. P-selectins are expressed on the platelets as well as the endothelial cells. E-selectins are expressed on the endothelial cells, and the expression of these selectins are increased in inflammation. Once the rolling is increased, then in the next stage what happens is the integrin expression is increased. These integrins are responsible for firm binding of the PMNs to the blood walls or blood vessel walls. So these are responsible for firm binding. These are integrins. And because of the firm bindings, later these PMNs, they start transmigrating. This transmigrating is typically assisted by PCAM1, which is also called as CD31 zipper molecule. CD31 zipper molecule. Why it is called as a zipper molecule is it helps in transporting the PMN through the gap in the vessel. You can see these PCAMs, they are just rotating here and they are attaching with the PMNs, and they are trying to push it out. While they are pushing it out, they try to seal up the gap so that there is no excess loss of the fluid from the blood vessel. That is why they are called as CD31 zipper molecules that limit the formation of edematous fluid. So if we just happen to summarize it, what happens is normally the blood vessel walls are inspected by PMNs by rolling. This rolling is increased because of expression of P-selectins, E-selectins. So increased rolling is because of selectins. Then we have integrins which cause firm binding. After that we have the zipper molecules or PCAM1. These zipper molecules help in transporting the PMNs out, that is a transmigration, and also prevent the excess loss of edematous fluid. Once the PMNs are out, they are supported by this fibrin and fibronectin, this extracellular matrix, and these extracellular matrix, it provides a pathway and they move towards the chemical signals by chemotaxis. So the weak and transient adhesion involve rolling. They are mediated by the selectin family. The next step is the firm adhesion of the endothelial surface, that is mediated by integrins. And then we have this migration of the PMNs, that is by squeezing. This migration is also called as diapedesis. So you have diapedesis here, and this PCAM1 molecule or CD31 molecule helps in the binding events which are needed for migration of the leukocytes. In all these events, we have noticed one thing is that is the PMNs, they are the first cell to appear in the acute inflammation, and later we have the monocytes and macrophages that come into the scenario after 48 hours. After the PMNs, they come out of the blood vessels, as we have already seen in the last scenario. These are the PMNs which are out of the blood vessel. They start moving towards the bacterial debris. Once they reach the bacterial debris, they start engulfing it. This engulfing is promoted by opsonin. Opsonin are the mediators that coat the bacteria and make it more tasty or make it palatable for the PMNs. These opsonins, the most important opsonins are IgG and C3b. These are nothing but the immunoglobulin, and this is the complement fragment formed by the plasma. So you can see these are the plasma mediators of the inflammation that act as opsonin. After phagocytosis, PMNs try to kill the bacterial debris by either the oxidative killing mechanism or the non-oxidative killing mechanism. Then we have the chemical mediators of inflammation. Herein we have the mediators which are cell derived, and we have mediators which are the plasma derived. In that we have the preformed mediators that consist of histamine and serotonin. This is very commonly asked MCQs. Histamine, they are secreted by mast cell, basophils and platelets. This is an MCQ. While serotonin is secreted by platelets. Then we have the newly synthesized, in that we have the prostaglandins, leukotrienes, PAF, reactive oxygen species, nitric oxide, cytokines, etc. Then we have the complement activation and complement systems that acts as C3A, C5A as anaphylactoxins. We have C3B, C5B to 9 which act as membrane attack complex. Then we have the kinin system and the coagulation system that also plays a role in inflammation. This is a list and the principal action of the cell-derived mediators and their source. We have seen that neutrophils, they are the primary players of the acute inflammation, but based on the type of infection, the inflammatory cell varies. And here we can see that we have the acute bacterial infection and abscess. The prime inflammatory cells are neutrophils. While when we talk of the chronic infection, the prime cells are macrophages, the plasma cells and the lymphocytes. Whenever we have a parasitic infection, we have eosinophils coming into the picture, which is also a scenario in allergy. In viral infection, the prime cells are lymphocytes. We talk a little about tissue macrophages here. The tissue macrophages are nothing but the monocytes that have reached the tissue. In the tissue, they are called as macrophages, and they have different names in different kinds of tissue, and we have included this slide here because again this is a very common source of MCQ. In the connective tissue, these macrophages are called as histiocytes. In the nervous system, they are called as microglial cells, or you can say only the glial cells. In the epithelium, they are called as the Langerhans cell. In the lymphoid tissue, they are called the dendritic cells. Lungs, they are called as alveolar macrophages. At this point, do you remember the heart failure cells, which are nothing but hemosiderin-laden alveolar macrophages? Alveolar macrophages had ingested the extravasated blood. Then in liver we have the Kupffer cells, and in granuloma these cells are called as epithelioid cells. Next we talk about the granulomatous infection. When an initial acute inflammation is not digestible by neutrophils, the mechanism that deals with such a scenario is called as the granulomatous infection. And the principal cells of granulomatous infection are macrophages and lymphocytes. We'll see about the few important granulomatous diseases. In that, the most important one, we have the tuberculosis. And the primary infection of the tuberculosis, it is called as Ghon's complex. It is seen in the individual which have not been immunized or who have not been previously infected. And this Ghon's complex occurs between the upper and the lower lobe. If you talk about the lobes of the lungs, the left lung has 2 lobes, while the right lung has 3 lobes. And this Ghon's complex, it occurs between the upper and the lower lobe. Primary infection, if it happens in the intestine, it is called as Stapes mesenterica. If the infection spreads through the blood vessels and multiply, this is called as miliary tuberculosis. And what is lupus vulgaris? It is a primary infection of the skin, primary TB infection, tuberculosis infection of the skin. The secondary lesions are called as a Simon's focus, and usually they are found at the apex of the lungs. If this mistake is there in the keynote as well, please correct it. Then we have the soft tubercle or granuloma with the central caseous necrosis, which is a typical of the tuberculosis. And BCG vaccine, it contains attenuated strains of the bovine type of tubercle bacteria. Yeah, we are just compiling up the key points over here. Scrofula. What is scrofula? Scrofula is the inflammation of the lymph nodes, tuberculous infection of the lymph. The next major disease, granulomatous disease, is the leprosy. In that we have the Lepromin test, which is a very common source of MCQ. Herein what is done is there is the intradermal injection of antigenic extract of M. leprae are given. An early positive reaction, it is called as the Fernandez reaction, while the delayed positive reaction, it is called as the Mitsuda reaction. And what it tells us is the hypersensitivity of the patient to the antigen. With this, we complete this part of the discussion. And when we talk about general pathology, it is a huge subject, and we are trying here in the class to cover up the basic concept, but we need to go a long way with reading MCQs and back referring these MCQs into the standard textbook, and the book of reference has to be nothing other than Robbins. Thank you.